just in case. And then, let's see, I'm going to start it here.
Was it Game of Thrones dragon? Was it Game of Thrones?
That was not a Game of Thrones dragon. That was actually a Elder Scrolls dragon. If anyone is, I play Elder Scrolls Online currently. Well, when I get a few moments free from the children, then I will play some of that. Yes. Yeah. So, anyone excited about Game of Thrones coming back? I just started him a few episodes in, but I really hope that Ned Stark goes all the way. I really think he's gonna. I'm just kidding. That was the joke, right? Anyway. Some of you guys don't know that. Wait a second, what? Who's that guy even? Yeah, so everyone got their assignment turned in, I hope. It's due this week, and then your test is next week. So good. And then so we're going to finish up the OB-GYN section, just a couple slides there, and then we'll hit the Peds Geri stuff. A lot of that's kind of review, so I'll be trying to get through some of that stuff a little quick so we can kind of talk about more or less, now that you have more perspective on the medications, right? So before when we covered it, it was more kind of nebulous. You're like, okay, well, I get that these are the pharmacokinetic differences between children and geriatrics, et cetera, but you didn't really have any perspective on how you're actually using drugs in those patients. And so now we have that perspective. We can talk a little bit more to that. Talk about like actual specific examples of how you're using medications for those patients, right? Anyway, any questions before we get started? All right, so getting started here with talking about, we talked about estrogens and progestins. Now we're getting into the inhibitors and the antagonists. If you remember, there's several spots along the pathway here where if we need to drop estrogen or progesterone levels, we can do that pretty simply, right? So either by inhibiting certain enzymes or by trying to activate that negative feedback loop, you can drop levels of things like FSH and LH pretty precipitously. So as an example here, when you have things like GnRH, which normally in normal physiologic levels will stimulate release of LH and FSH. If you give too much of that, you can actually shut down the whole system, right? So you can actually shut down further release of that. That's a pretty potent way to do things, right? You're going to get a lot of big drops in the estrogen levels. If you did that to a male patient, what do you think you'd see? Decreased libido, right? Because you have way less testosterone levels, right? So FSH and LH are going to be treated essentially the same between male and female. It's just a matter of when they get down to their sex organs, what it's going to be producing, right? So that's one way to do it. You can do things like, certain enzymes can actually inhibit the production here. So like ketoconazole is an example, even though clinically you don't use it for that purpose there. But the other big one's going to be the aromatase enzyme, right? If you remember, progesterone and things like that are going to get converted over into estrogen via that aromatase enzyme, right? So if you were to maybe inhibit that enzyme, you'd have pretty big drops in your estrogen levels as well. And who might that be useful for? Patients who have breast cancer that is responsive to that estrogen, right? Because what does estrogen do in the breast tissue? Yeah, stimulates hyperplasia in those women who are susceptible. Can stimulate, kind of rampant reproduction of those breast cells, and that's where you get the breast cancer, right? So that's one way we can do it. And then again, we're going to find that when the estrogens actually get down to the nucleus, where they actually cause their actual mechanism here, we can have drugs that can block that as well, right? So we'll look at some drugs that have kind of mixed actions, where they can be an agonist and an antagonist depending on what tissue we're looking at. And so we'll cover those in just a second here. So we have those drugs called selective estrogen receptor modulators. If you're SERMs, that is what we're referring to. The first one has tamoxifen, and this is still used fairly commonly for patients with breast cancer. The thing that it does is it works as either a partial agonist or an inhibitor of estradiol, depending on which tissue you're looking at. So for instance here, it's going to be an agonist in the bone and in the endometrium, but it's an antagonist in the breast tissue. So good for patients with breast cancer. But again, if I were to say give an aromatase inhibitor and drop down those levels of estrogen, what happens to those women's bones? They become osteoporotic, right? Because you lose that positive effect on that estrogen has on the bone there. So this is nice because you can get rid of the breast effect of estrogen, but you're going to find that you are getting the positive effects on the bone. However, what could be the other risk? Endometrial cancer, right? So again, if you had a patient at a hysterectomy, no big deal, right? However, if they still have an intact uterus, this may not be a good option for them. So it's going to be something where you'll find that has mixed actions depending on the tissue that you're at, because again, the nucleus and again, what response elements it has there on the DNA can be a little different depending on the tissue you're dealing with. Now, again, what kind of side effects would you expect to see? It may have a kind of excess androgen levels, right? So you can see things like hirsutism and whatnot. What other things? Vaginal dryness, you can see dyspareunia, right? What else? Vasomotor symptoms like the hot flashes can happen there, right? Because again, you're dropping down those estrogen levels. It's kind of like inducing menopause in those females that they have not gotten to that point yet.
Okay, so you're talking about if the female was not already perimenopause.
Mm-hmm.
Okay.
Yeah, exactly. Yeah, so they were still producing some of their own estrogen. Again, depending on the patient, it depends on when they actually develop the cancer, when that would actually occur there, right? So again, you're taking the patient. It's a very much on a case-by-case basis there, as you'll learn when you do your OB/GYN rotation if you deal with any of these patients. Again, vomiting is another pretty common side effect for this one as well. So, this is good because it helps with things like, lumbar spine density in some of these women there. It helps to prevent some of these fractures. Actually had some positive effects on lipids, things like that. And so it was good. However, you do still have some risks. Things like the thromboembolic risk were still present with this one because it did have some liver effects. It still had risks for things like endometrial cancer, vaginal bleeding, etc. Because again, this would have positive effects, would cause hypertrophy of that endometrial tissue, right? So some negative effects with that. However, there are other drugs we can try as well. Things like raloxifene. Raloxifene is going to be good because it has estrogenic effects on the lipids and the bones, so positive from that standpoint. But this one actually didn't stimulate the endometrial tissue. So if you had someone maybe with an intact uterus, this would be a better drug than something like tamoxifen. Okay. And again, you're going to find this can not only just be used for breast cancer, but you can also actually see, and again, it's not a high-risk omen, should be high-risk women. But the other big thing here is that it is good for helping with that postmenopausal osteoporosis. Okay, so if you had a patient who maybe had high risk for breast cancer in their history and you didn't want to give them hormone replacement therapy, you can give them something like this instead and still help with their bones, right? So that could be an option there. Another agent here called clomiphene. This is actually an older partial agonist, and this actually will work to inhibit the negative feedback loop, kind of higher up on the HPA axis, right? It's actually working between the hypothalamus and the anterior pituitary there. That actually will inhibit the negative feedback loop, and we actually use this very commonly to help stimulate ovulation. So if you have a patient who has a hard time conceiving, so they've been trying for a few months and nothing's really working, sometimes they'll use Clomid to actually try to stimulate that process again. But it's working as a partial agonist to kind of disrupt the negative feedback cycle and can sometimes stimulate ovulation. So sometimes you'll see that. Yes, ma'am.
Sorry. So you know how estrogen has the cardiovascular, like protective, kind of.
Yeah.
So with those SERMs, would they increase the risk of like a heart attack?
Depends, right? So if you saw that it has positive effects on increasing clotting factors, then you have to worry about it from the thromboembolic standpoint, right? So you could see something from that. On the other hand, though, if it's having positive effects on your lipid profile, and over the long term, if it's decreasing atherosclerosis, then maybe it has a bit of a positive effect. So that's kind of what they found in that big women's health study, is that it's kind of like, well, yeah, it's kind of like, well, if there's no clear benefit of one. It's not a clear thing like, hey, you've had a heart attack before, now we're giving you aspirin, and now we know we're decreasing secondary events, right? It's not like clear-cut advantages like that, or giving someone a statin or something like that. So again, it's one of those things where you take the good with the bad. If they have like a thromboembolic disorder, like you probably wouldn't want to use it, but if they have, pretty poor lipid profile, maybe it's a good option for them. Just depends on the patient. Anyway, some other agents you could potentially use as well. So this is actually an estrogen antagonist. So again, the side effect profile would be much more severe with this than you would see with a selective agonist, right? Because this is acting as an antagonist everywhere. So this is one called danazol. These are typically used as for patients who maybe are treatment resistant to things like tamoxifen. They kind of fail those therapies, and you can use this as a backup agent potentially to try and get some additional anti-estrogen sort of effects for those patients there. Other things you might see it used for include things like treating endometriosis. You can see this sometimes used for certain hematologic disorders. Again, the full mechanism there we don't have necessarily the full story on, but you may sometimes see this being used for patients like ITP or hemophilia. I've not personally seen this used too frequently, but depending on where you work, you might see that. And again, the side effects are going to be pretty predictable because we're decreasing the estrogen effects. You're going to see more of those androgenic effects. You're going to see more of those progesterol effects. That's why you see the edema, the weight gain, decreased breast size, right? Because you have less estrogen effects on the breast tissue, deepening of the voice, right? It's part of that androgenic sort of effect there. Okay, and again, those are things you'd expect to see just based off the mechanism. Other things we have include aromatase inhibitors. Again, because these are so severe in dropping estrogen levels, you're going to see a lot of menopausal sort of side effects associated with this. They're usually used as backup if something like tamoxifen fails. But again, by inhibiting the aromatase enzyme, you drop estrogen levels 80–90% in some cases there, so it's very, very potent agents. And keep in mind, some of these are going to be irreversible versus reversible. Which one do you think would be more potent at dropping estrogen levels? Irreversible, right? Because again, you have to produce new aromatase in order for that drug to actually, for the enzyme to actually work again. So just be aware of that. Again, big risk for fractures with these because we're getting no positive effects on the bone. You're decreasing estrogen activity everywhere because you have less estrogen overall. So again, fracture risk is going to be a big thing with this one. Okay. So any questions on that section? If not, let's move into talking about pediatrics. It's kind of like a special populations kind of thing here, but and some of this may look familiar because we talked about this a lot with pharmacodynamic or the intro to pharm class back in the summer, right? All those many months ago. It's good to kind of talk about that at the beginning, and now we're ending with this topic again. Here right at the end. The full circle, right? Life is just all about circles. Anyway, so why are pediatrics so hard? Why are people so worried about dealing with pediatric cases, pediatric patients? So delicate, they're so little, they're so fragile. If you ever want to see some really anxious people, go to an adult ER where all they do is adult stuff, and then bring in a pediatric code. Those will be the most high stress, high anxiety people you've ever seen in your entire life. It's scary, right? Because some of these kids, if you're not used to dealing with them, they're so little, they're so fragile, you worry about them, you're just like, what do we even do with this? A lot of times, especially like EMS, like you may find they do the scoop and dump, where they basically go out, pick up the patient, they try not to do anything, just keep them alive, and then drop them off at the ER, because pediatrics is kind of tough, right? Unless you deal with it all the time, and you kind of get used to it. And that's why I put a lot of those pediatric prescriptions on your assignments, so that way you get used to doing drug dosing for different size patients, and you kind of get used to the math behind it, right? Because again, when you're in the heat of the moment, when you have a 10-kilo patient coming in, I got to figure out how much epinephrine to give them, and you're trying to convert between concentrations and the dose and all these things. In a high-stress situation, it's really tough, right? Imagine, you guys are high-stress during test time. If you had math problems on your test, try doing that when you actually have a live, dying patient in front of you, right? It gets very, very stressful. So that's why we try to get you at least somewhat familiar with it. Try to immerse yourself in the stuff with the pediatrics, rotations and things like that, so that way you're a little bit more comfortable with it. But again, we know they change drastically depending on what age you're dealing with, right? So someone who's 2 days old is going to be much different physiologically than someone who's 2 years old, right? Even just seeing the difference between my 15-month-old daughter versus my near 3-year-old daughter, it's incredible, right? Just to see like just the brain function is just so different, right? She's making sentences and she's now just starting to walk, but it's just incredible to see how a short period of time can make really big differences for those patients there. Now she's climbing upstairs on her own, and now that's really dangerous. And she's silent, incredibly silent. Just turn around for 2 seconds, and all of a sudden, she's upstairs. Anyway, again, it's important to think about things like gestational age when you're dealing with, especially infants, especially neonates. Again, what do you consider to be the neonatal period? Yeah, the first 28 days of life, essentially, right? The first month of life is what we consider to be the neonatal period. The reason why we talk about gestational age so much is because a lot of times your drug dosing is going to be based off of what their gestational age is. So when you go and look in LexiComp, you'll notice that most of the times if you go into, how there's like the adult Lexi and then there's Peds Lexi? That's important they have that difference there, because when you go into Peds Lexi, very frequently they'll have a neonatal section and then they'll have a general pediatric section. And if you look at that, you'll notice that sometimes things are broken down based off of what their gestational age is. Some is based off what their postnatal age is, right? What's the postnatal age? We'll look at it in a second. But right, postnatal, just the chronological age, right? Once they've been born, so are they 2 days old? Are they a week old, right? Post-conceptional is just kind of the two put together. That one you don't use as frequently, but keep that thing in mind, right? So by looking at that, you can change your drug dosing pretty significantly. As an example, something like gentamicin, what kind of drug is gentamicin? Aminoglycoside. We use it very frequently for ruling out neonatal sepsis, right? So if a kid's born, they develop a fever pretty early on, or maybe they're premature and mom was GBS positive, things like that, we will put them on prophylactic antibiotics, right? Gentamicin, ampicillin, some combination thereof. And so based off the gestational age, if they're less than 34 weeks, or if they're greater than 34 weeks, we will change the dosing pretty greatly, whether it's Q24-hour dosing, Q48-hour dosing, Q36-hour. And why do you think that difference is there? Why does that matter? So water is going to play a role, right? So that can affect volume distribution. Metabolism is a big thing as well. Did anyone remember how you get rid of gentamicin? The kidneys, right? Yeah, all through the kidneys, right? So again, think about if a kid is born, and what's the term birth? Like how long? Yeah, 37, 42 weeks, somewhere in that range there, right? So if a kid comes out and they're 24 weeks, have they had time to really develop the same sort of nephrons, either the quality or the quantity, as someone who's born at 38 weeks? Absolutely not, right? So again, even though you may have two children who are 2 days old, one might have been born 2 months early versus one born at the right time, and you're going to see that physiologically they are extremely different, right? And their drug dosing will be very, very different based off of that, right? Not only the dose you're administering, but how frequently you're administering it, okay?
Is there a location in lexicon for post-conceptual age, like for premature kids?
Yeah, as I mentioned, you typically don't see post-conceptional age used too frequently. They'll either base it off of the actual chronological age, the postnatal age, or looking at the actual gestational age. And so once they get out of that 28-day period, then you kind of go just to general pediatric sort of dose in there. We'll look at some options there in a few minutes.
I was just thinking about like, what if a baby's extremely premature? Like my friend had one, her baby at 25 weeks.
Mm-hmm.
So obviously, just because that baby's a month out since being born
Mm-hmm.
doesn't mean she's really like a month old.
Exactly, yeah. So it takes a long time for them to really catch up with their peers who were born maybe at a normal term length. And so based off of that, you still will look at things like, gestational age potentially for helping even a month out, right? Because again, just because you hit a month old does not mean that we kick you out of the NICU, right? Some of these kids will keep them there for near a year sometimes, depending on just how, if they're not stable, if they're not able to grow and get out of there, right? So these are all things to consider, right? So, and again, that neonatal period, and sometimes, when we say infant, sometimes we'll use that to refer to people who are just born, right? We'll sometimes use that neonatal period and refer to them as infants, but really infants is that 1 month to 12-month time frame, right? The neonatal period is that first month there, the first 28 days. And then obviously, 37 to 42 is what we consider to be a term birth. Anything before that is premature. What's the usual, what's kind of the earliest a kid can be born and still be viable? Usually 24 weeks or so, right? Sometimes you can do it a little bit earlier, but they are very, very tenuous. They're very, very sick kiddos because, again, they're just not ready for the world yet, right? They need to stay in the oven a little bit longer. But here they are, and you got to take care of them, right? But that's why it's super, super important to make sure you're looking up stuff beforehand because, again, physiologically speaking, you have two patients who are the same age, but gestationally they are far different from one another. Anyway, you get to the toddler range, young children, etc. Now, when do you start to treat these kids as adults in terms of drug dosing? Certain weight. Yeah, typically you're looking at weight, right? So again, what kind of weight would you be looking at? They start to get around adult weights, right? What is an adult sort of weight? Depends on the type of patient, right? Once I start to get around 50, 60, 70 kilos, then I'm starting to think more like adult dosing, right? Because again, when you're looking at a lot of pediatric dosing, what is it based off of? Like what are the units using? Based off weight, right? So you're milligrams per kilo, right? Or micrograms per kilo, something like that. Once you start to get above adult dosing, you need to cap yourself out, right? Because again, I wouldn't want to give more than I would give an adult just because they happen to be a large child, right? So, for instance, we have a deal with Disney. So if we have a football tournament or a cheerleading tournament at the Wide World of Sports, someone gets injured, they'll come over to us, right? So again, you could have 120 kilo football player you're dealing with, but I'm not going to give him more than adult doses, even though he's that large. Even though I would say 1 milligram per kilo might be a dose for something, right? So if he gets a fracture and we need to reduce it in the ER and we're giving him ketamine, I'm not going to give him monster doses of ketamine just because he's a monster size of a child, right? We're going to give them normal adult size dosing. I don't use that term in denigrating sort of sense there, but you have kids of all kinds of sizes. I've seen kids who are 17 to weigh like 25 kilos, right? And sometimes they have severe growth delays and things like that. So you find all of the whole gamut, right? Anyway, again, know that these changes are going to occur. They're pretty predictable for the most part. So again, kind of going through the different pharmacokinetic profiles here. Just remember that absorption can change. So thinking about the pediatric patients, thinking about the neonate specifically, how does their skin differ from, say, an older patient? Very thin, right? So what do you think that does to drug absorption? Increases pretty significantly, right? So again, you can find that a lot of drugs may not be able to partition across an adult skin and go through the pediatric skin or the neonatal skin, right? Because they just have not developed that stratum corneum, right? It's also very, very well hydrated too, right? That can also help as well. Remember what I kind of likened infants to, or neonates to? Big bags of water, right? So again, looking at the kinetics, you're going to find they have a lot of body water, and so that can lead to big differences in distribution. Sometimes absorption as well can be affected here. So looking also at things like pH and pKa. So imagine a child is first born, say they're in that first 24 hours of life. How do you think their stomach pH compares to, say, someone who's maybe a few weeks out or a few months out? Why do you think it'd be higher? Yeah, think about what they've had in their GI tract so far. Well, they haven't really had to produce a whole lot of stomach acid, and they've had a lot of amniotic fluid. They're just kind of passively swallowing there, so you end up finding that you're measuring pretty alkalotic, if anything, pretty neutral, right? And so, again, over time, you're going to find that that can affect drug absorption, right? So, again, if I had a weak acid, remember, light dissolves like. If I put a weak acid into a basic solution, it's not going to really absorb all that well, right? So that can affect drug absorption. Think about things like if I have a neonate that was born and say they have neonatal abstinence syndrome. Remember what that is? What is that? Yeah, they're withdrawing from whatever the mom was taking during the pregnancy there. They have a hard time of managing their temperature very well, so usually have them under the easy bake oven lights, But think about things like absorption from the intramuscular space, right? If I give them an intramuscular injection and they're not able to really control blood flow all that well, they're not really doing their temperature control well, what do you think that does to absorption? Well, decrease, right? Slow it down because, again, you're not getting that good blood flow to pick up that medicine from the muscle and then deliver it out to the systemic circulation. So these are all things you expect to see as far as differences go in absorption. And again, remember I talked about that one story about the, probably mentioned it to you, where there was an infant who had a lot of diaper rash, and the mom went ahead and accidentally, she thought she was applying the typical, like, the Boudreaux's butt paste or something like that, and instead accidentally applied dad's specialty compounded pain cream, like for his back pain, that had ketamine and lidocaine and all kinds of stuff in it. And again, think about, kids' skin with diaper rash is pretty inflamed, it's red, it's hot, right? And then right after a bath time, so, the kid's nice and warm, and then you're slapping the stuff on, and then what do you put over it? A diaper. What is that? It's an occlusive dressing, right? What does that do to absorption? All of that increases it greatly, right? And they find the kid apneic, have to get him into the ER, intubate him. Kid does fine. However, you can measure ketamine levels, right, in that patient's blood. You can measure other levels of drugs that were there. So again, consider the fact that this absorption is going to be pretty good, especially from a dermal standpoint. But think about things like the GI absorption. Think about other things based off of these properties here that we're talking about, right? As I mentioned, what do you think about gastrointestinal emptying time for these kids as well? Usually pretty, well, the time is not increased, right, but the rapidity is increased, right? So, and again, if you're thinking about bowel movements in an infant, how frequent is it compared to an older kid? Yeah, it's like 5 to 6 to 7 to 8 poops a day, right? It's a lot, right? Especially, and it can depend on what they're being fed, right? Whether it's breast milk, whether it's formula, et cetera. If they have any kind of dietary issues that are going on as well, that can affect it. And then once you start to get a little bit older, let's say they get around to the year of age, how many times are they going? Much less, yeah, maybe 1, maybe 2 a day. Usually they'll get much more in a normal cycle as well once they kind of start to transition from having those little, kind of really liquidy sort of poops over to like more solids, right? So it's a difficult transition for parents because all of a sudden you're like, oh, baby poop's not so bad. It doesn't really stink that bad. Once they start getting on solids, it's real bad, right? Yeah, it's not fun. And it's not fun for them, too, because, again, their GI tract's not used to that. So now they start getting constipated and you start thinking about giving them glycerin suppositories and all this stuff. It's a big deal. Not that I know anything about that, right? But anyway, but you can find that when you have that really short gastrointestinal emptying time, you can find things like drug absorption may not be so great, right? You may find that drugs are passed through too quickly. So say, for instance, you try to give a long-acting formulation of a drug to a Peds patient, you may find you don't get time to absorb all of that, right? Clinically, it's not too big of an issue there, but just know that time will change based off of how old they are. As they get older, it should start to slow down. We'll find they're going to have less bowel movements, et cetera, right? And these are predictable things. Okay. As I mentioned, we talked about the gastric pH, how that's going to change. It takes some time to really kind of kick up that acid production on their own, and that can affect oral absorption of medications. And again, we're still giving, even if it's a neonate, not everything is going to be given parenterally. We still give some things enterally, so you guys still have to consider this depending on the drug that you're dealing with. And again, are you actively having to think about this when say you're working in the NICU? No, but a lot of times Lexicomp has already taken that stuff into account, right? Your drug reference of choice will already look at the dosing and they'll have adjusted for that already. But just know this is what goes into making those changes there, right? And again, you want to have a good idea of the concepts behind why dosing changes between a neonate versus an infant versus a child versus an adult, okay? As I mentioned, the gastrointestinal time, sometimes this can actually be affected by blood flow as well. So if you think about kids with congenital heart defects, you may find they are not perfusing super well. Less blood flow to the GI tract is also going to slow things down pretty significantly. So other things to consider as well, right? Let's see. Again, as I mentioned, less time the drug has contact with the GI tract, less likely it is to be absorbed. That's why we don't use a lot of long-acting formulations for these kids. Just something to consider there. And again, that may account for why you have differences in actual blood levels of drugs based off of things like oral absorption, right, depending on the gastrointestinal time. Anyway, looking at other routes of administration, so I mentioned the muscular blood flow can be pretty reduced in neonates, but again, it gets to more normal patterns by the time you're between an infant to a child. Again, think about as well, once infants are starting to get a little bit more control of their limbs and they're starting to move around a little bit more, that's why you see that kind of increased activity. This will help with getting more drug absorbed there. I mentioned the mucosal and the skin permeability, also very, very good places to absorb medications for those patients there, right? Again, what's a good route of administration for a neonate? If we're not giving it enterally, but we're not giving it IV, what's another good? Rectally is a great one, right? So again, if you're using rectal Tylenol or something like that, because again, it has very good absorptive capacity. It's a very well vascularized, thin membrane sort of area. You get a lot of good drug absorption. Okay, yes, sir.
Does nasally have the same kind of increased absorption?
Yeah, I don't see a whole lot of intranasal drugs being used in the neonatal patients. Certainly, if you have like an infant or something that presents to the ER, like we've used it before. But yeah, they still have the same good absorption, just like anyone else would in those cases there. But I'll also have to think about if I were to put a suppository into the neonatal patient's, rectum. What do we talk about with the GI tract? The patients, yeah, they have very frequent contractions there, right? So you have to make sure they're not just going to spit the medication right back out as soon as they feel that stretch response there. And so you can hold their cheek shut until the medication has time to melt and actually get absorbed, right? Those are the things you want to consider. Because very frequently you'll have parents will complain about, oh yeah, I put the medication in there and I check like 2 seconds later and the kid already pooped it out, right? Again, you have to hold it there, make sure it gives it time. That the suppositories usually have like a cocoa butter base, and it takes time for them to actually melt and actually get absorbed there. Okay. As I mentioned, intramuscular absorption can be erratic depending on the patient, depending on how well they are controlling their temperature, how well the blood flow is actually going. If they're not moving around a lot, you may not see very good blood flow there, so you may see variable rates of absorption. The same total absorption will happen because, again, the bioavailability of an intramuscular dose is what? 100%, right? I'm putting it right there in the muscle, right? It has nowhere else to go. But it may take time for it to get into the system. It may slow it down. So you may not get the same kind of quick effects as you would expect to see with someone with that better blood flow there, right? Also keep in mind the apparent volume of distribution for those medications as well. So with a neonate, I mentioned they're big bags of water. So they have a lot of body water as compared to someone who's a little bit older. And so what you find is that for hydrophilic medications, what happens to their volume of distribution? It's a lot bigger, right? It has much more area for the drug to distribute out to. And I'll show you some examples of drug dosing and how it changes based off of that. But do you think that affects your frequency or your dose more often? It affects your dose, right? Because that dose has more area to partition out to, I have to give a bigger dose to get the same blood level, okay? As opposed to lipophilic medications, may have a relatively low volume distribution, right? Because they don't have a lot of fat tissue so much. And you'll frequently see this, especially when kids are first born in the first day or two, that they tend to lose weight. What do you think they lose that weight? Yeah, they tend to diurese a lot of that water out, right? So that's one of the things they usually check for, especially like in your well visits when they're first coming back after getting discharged from the hospitals. You want to make sure they're putting weight back on, right? So again, getting back to whether kind of their birth weight was or a little bit above. I remember one time because my daughter was born on 12/20, right? So it was right around Christmas time, so we wanted to get her seen by the pediatrician, but we knew that Christmas was going to kind of interfere with that. And so we got her in right before Christmas, and the doctor was like, well, her weight's kind of a little low. We got to watch her and make sure. Of course, we're like anxious about her eating enough. My wife was anxious about her eating enough the whole time to put weight back on. And then sure enough, by the time we got her back in right after Christmas, guess what her weight was? It just had skyrocketed, right? She was just like, don't worry, my kids can eat, right? Not an issue. But of course, sometimes it could depend on when you actually get in. So we got in there pretty soon, and so she was still diuresing a lot of that water off, and that's why her weight looked low compared to what it would have been just a few days later. Okay, those are all things we expect to see. As I mentioned, rectal absorption, very good, but keep in mind that an increased amplitude of contractions is going to sometimes cause that to spit the medication right back out, so you got to make sure you kind of hold those cheeks shut for at least a few minutes. And again, if you can't get an IV, because IV access can be pretty tenuous in these little ones, what can you do? Well, we get an IO, right? So again, basically, you get this nice little drill, and again, depending on the size of the patient, you get a different thumbtack, basically, you're going to be attaching onto there, and just drill right in, right? Relatively painless, from what I've heard. They say it's painless, or less painful. Not much more than an IV. I've never had one done, fortunately. But what's your experience? Yeah, right, because again, we're pushing it into the bone, right, into the marrow, and so it's basically a big non-collapsible vein, right? So you can push code medications, you can push fluids, all that stuff, right? But again, it's kind of you're pushing fluid into a non-compressible space, right? So that pressure may end up causing some pain there. But what are some sites that we can get the IO into? The tibia is a very common one. You could do the sternum. I don't see the femur so much, but like the humerus you could do. Those are the common ones I think about. The tibia is probably the most common one I end up seeing there, just because it's easy to get access to the patient's leg, especially if you're like actively coding the patient. Like you obviously wouldn't want to do the sternum. The arm might be hard to get access to, so the tibia is pretty common there. But again, it's nice because you can use it for emergent situations. You can get access within just a few seconds. As I mentioned, the percutaneous absorption is going to be improved for many medications, and again, that can lead to issues. I don't know if you remember me telling you a story about those patients who were born, and then they had tested them for the presence of drugs, and they found THC in the urine, and they're like, oh man, the mom must be smoking marijuana during the pregnancy, and they go and check the mom, and they found out the mom was negative. So Was the baby lighting up in the nursery? Probably not, right? But they actually found there's a moisturizer they're using on the patient that actually got absorbed, and one of the components of that moisturizer actually cross-reacted with the THC assay, right? And so again, they had really good absorption. That's why you ended up seeing that. Mom might have gotten the same moisturizer, wouldn't have tested positive because she has a thicker, more developed stratum corneum.
What?
I think it was like an Aveeno product or something like that. But again, the assays are looking for a specific molecule, and again, if it looks similar enough, it'll trip it, right? Yeah. So it wasn't like they're using like hemp oil or something like that. Yeah, it was just something that looked similar enough that it ended up cross-reacting there, right? So if anything, just be careful. This is why a lot of times certain cleansers cannot be used on neonates, especially like isopropyl alcohol. They don't use that anymore. It actually led to hypoglycemia due to the fact they don't have a lot of good glycogen stores. Seizures have happened by putting things like Benadryl lotion on these patients there. So this is why we avoid that. Just be aware their skin is very likely to absorb a lot of stuff. And then we talked about distribution. Obviously, volume distribution is going to be a factor looking both at the dose that we're administering and then the resulting blood concentration, right? Again, we're not actually measuring the volume of where this drug is actually going to. This is all just kind of a surrogate that we're using. But it's a good kind of secondhand or kind of another way of looking at how distributed out does this drug go, right? Does it stay in the blood or does it go out into the tissue? And as I mentioned, because neonates are going to have a very high body water content, for hydrophilic medications, volume distribution is going to go up, right? That drug is going to partition out, which means my blood levels should go, they're relatively low as compared to that, right? Because the drug's not there in the blood anymore, it went out to the tissues, okay? So again, looking at things like lipid solubility, protein binding, what does protein binding do to volume distribution? It decreases it, right? Because again, if it's plasma proteins, you're going to find that they're more bound up and all that drug is stuck in the blood as compared to it getting partitioned out to the tissues there, right? Tissue binding will have the opposite effect. It will increase your volume distribution because all the drug is being stuck out there, right? So all things to consider there. And again, look at the kind of concomitant conditions that are going on here. If the patient is very edematous, that's going to affect volume distribution. If they are very dehydrated, that's going to affect the volume distribution. That's going to affect your blood levels pretty significantly, right? So to mention a lot of body water here, less fat tissue, less muscle tissue. So when you're looking at things like dosing of gentamicin, you're going to find that the dose is relatively high on a milligram per kilogram basis as compared to an adult. That is in order to get the same blood level, right? I think I have it on the next slide. Basically, they have a much larger bucket that you're trying to fill that drug with as compared to the adult bucket, which tends to be a little bit smaller, right? Again, I don't condone putting your children in the buckets, but again, sometimes a good way to keep them in one spot for just a few seconds when you need. Just kidding. But just to give you an idea, looking at the volume distribution for gentamicin between a neonate to an infant to an adolescent or an adult, notice here it's much larger, 0.5 to 0.6 as compared to 0.2 to 0.3. That means that when I put that same relative dose of drug into the patient, like on a milligram per kilogram basis, right? I put 4 milligrams per kilo into a patient, whether it's a neonate or an adult, you're going to find that neonatal level, the blood level that I pull is going to be much lower because all that drug partitioned out to that body water, versus for an adult patient, the level will be much higher. That means that for the dose I have to administer, maybe giving 4 milligrams per kilo for a neonate versus just 1 to 2 for an adult. These will result in the same blood levels between the two by taking into account changes in volume distribution, okay? That's important, right? Because what happens if I give 4 milligrams per kilo to an adult patient? I would have too high levels and they potentially lead to toxicity, okay? So this is why it's important to take into consideration. If I gave a neonate 1 to 2 milligrams per kilo of gentamicin, what would happen? Levels are too low, right? They have meningitis that they're nursing, right? And then all of a sudden you're not giving them enough drug, they could die, right? So these are all things you want to consider, right? Okay, so typically you're going to find they have decreased plasma proteins, they'll have less protein binding. All of these things are going to lead to that distribution being altered to a pretty great extent there, especially during that first month of life or so. Also think about other endogenous products that are competing for binding, right? Think about bilirubin. If you remember, there's a certain cephalosporin we don't want to give in that first month of life. Anyone remember what that is? That's ceftriaxone, right? Because it competes for the binding sites for bilirubin. If I give ceftriaxone, it's going to kick all that billy off, and guess what the baby's going to look like? You're going to look like a little piece of corn, right? Because they're going to be a little jaundice baby. You want to do that, right? So again, that's why drug selection is very important. And you'll learn that. You'll say, okay, well, this drug is not good for the first month of life. And then once they hit a month, then generally the bilirubin levels are down low enough. You don't have to worry about it so much anymore. Other things like phenytoin, right? Phenytoin, if you remember, is very highly protein bound. If you don't have enough proteins there in the blood, you have a higher free fraction. And that can lead to what? More therapeutic efficacy in some cases, or more toxicity if you don't take into account. So I have to look at things like free levels potentially. So again, just know that in the neonates may see these are being fairly reduced for the most part, but then as time goes on, by the time they're an infant to a young child, they should be relatively close to what the normal adult levels would be for the most part. Okay, looking at metabolism of drugs here for these patients, what are some things that will factor into this? So when a baby is first born, are they producing all the same CYP enzymes as an adult would? No. Does that mean all their pathways are deficient? Not necessarily, right? You may actually find some pathways are actually more plentiful than an adult patient would be, right? There's actually, if you ever look at, if you ever get to toxicology, right? If you look at, potentially dangerous doses of Tylenol for a child versus an adult, the child can actually tolerate a bigger milligram per kilogram dose than an adult can because they have better sulfation pathways, right? So not every pathway is going to be diminished as compared to an adult, but just know that it's going to be different depending on which drug you're dealing with, okay? And again, you don't have to actually think about that. You're not thinking, okay, what's their sulfation pathway percentage right now versus their expression of CYP2E1. You don't have to think about that. What you do want to consult the dosing, though, and that will give you an idea of, okay, well, how does the dosing change if I'm dealing with a neonate versus a young child, right? And it's already taken into account for you. So again, remember your phase 1 and phase 2 reactions. You remember the difference between those two? What's a phase 1 reaction do? Because what's the ultimate goal of metabolism? Yeah, to get it more water soluble, so typically you can excrete it through the kidneys, right? Or through the bile or wherever it's going to go.
Like adds groups to it.
Close, that's phase 2, right? So remember, phase 1 is usually going to remove something or uncover a functional group that makes it more water soluble. And then phase 2 is when you add something onto it, right? A methyl group or a sulfate group or something like that. Remember that not every drug has to go through both pathways. Some will just go through one. Some will just go through phase 2. Some will go through both. Some may go through none, right? Depending on what pathways that it gets metabolized by. But just as a brief reminder, remember phase 1, the most important pathway we have here is our oxidation pathway. The most important family of enzymes there is what? CYP3A4, cytochrome oxidase, P450, right? 3A4 is the most common one you're going to run into, but remember there's plenty of other ones as well, right? What are some other big ones we've talked about? 2C9 is a big one. It's a big one for warfarin. 2D6 is a big one, especially for like psych meds and beta blockers and things like that. 2C19 is another big one for warfarin. Yeah, so those are some of the common ones. But obviously, if you did not remember any of them but one, when you left here, 3A4 is the one I would want you to remember, right? Because it's the most common thing you're going to run into. And just know that you're going to find that, especially like a full-term infant, it could be approximately half the activity of an adult patient, but the more premature they are, the more likely they are to see underperformance of those enzymes, just because they haven't had time to really develop them yet, right? And again, just to give you an example, certain drugs may have increased metabolism as compared to adult patients. So as an example of phenytoin, by 1 year of age, we're having to give 2 to 5 times the normal dose that I would give to an adult because they are metabolizing it so quickly, right? And so just know when you're looking this stuff up, that's why those differences in doses are there. They've already taken this stuff into account for you, okay? And again, certain things will mature at different rates. 2E1 tends to go pretty rapidly within a few hours of birth versus things like 3A4 may not really be all that present until the first month of life. Again, you don't have to memorize these facts, but just know that this expression is going to change as the patient's getting older. Drug dosing needs to be readdressed, right? And again, just like your patient's weight is constantly changing, especially during that first month of life, you have to go back through and readjust your doses. Also think about how old they are and going back through and readjusting doses based off of this stuff, okay? I mentioned phase 2 pathways are just where you're adding something on like a methyl group or sulfate group. Again, still clinically important. This is actually a good example of, let's see here. This benzyl alcohol here. So benzyl alcohol is a preservative you actually find in a lot of, if you ever look at a vial of a drug, like an IV product, and it says multi-dose vial, chances are it has a preservative in it, so that way you can inject into it multiple times and it's still sterile, right? Or the drug is still preserved, is still stable. Well, you'll find that in neonatal patients, they cannot process this glycine conjugation very well, which means they can't process the benzyl alcohol, and so they end up developing this metabolic acidosis. They get this gasping syndrome that occurs because of that, and has killed patients before. So that's why it's super important that when you're dealing with NICU patients, all your vials need to say single use or preservative free, right? If you ever see PF after a drug, it's an IV product, it means preservative free, and that's something you need to keep in mind with these neonatal patients. Because if they get the wrong preservative, specifically benzyl alcohol, that can lead to some pretty significant metabolic acidosis and potentially death, right? Anyway, so just some examples of things that will change over time. Sulfation pathways are extremely well developed as a kid's born, so that helps with Tylenol toxicity. But again, these are just examples. There are plenty of other ones that are out there as well. Excretion. What do you think renal function does for the neonate when they're first born? Is it good? Is it bad? Does it depend on how mature they were when they were born? Definitely, definitely. You're going to find that the more premature they were, the less likely they are to have good function of the kidneys, which means that half-lives of drugs that are excreted to the kidneys are going to do what? It's going to be a lot longer, right? So again, because the half-lives of those drugs will be much longer, what do I need to do with the dose and frequency? You got to extend it out, right? So as an example, I use gentamicin. For a kid who's born full term, I may be able to give the dose every 24 hours. For kids maybe born, say, 28 weeks. Maybe I'm giving every 36 hours. If I say I have a kid who's born at 26 weeks, maybe I'm giving every 48 hours. And again, I don't have the weeks memorized in my head, but guess what I do when I have one of those patients? I'm double checking the dose the provider wrote for. I look it up, right?
Now, is this when you give them a higher concentration of the drug, but then spread it out longer?
So remember, the dose is being affected by their volume distribution. So I have to give a bigger dose in order to get that concentration in the blood to an appropriate level. But then I have to give it less frequently because they're not clearing the drug as well, right? So that's the whole difference there. So again, the frequency is being determined by the metabolism or the excretion. The dose I'm giving is being determined by the volume distribution, okay? So those are important factors to consider there. So again, for gentamicin, I'm giving a much bigger dose on a milligram per kilogram basis than I would an adult, but I'm also giving it much less frequently. An equivalent dose for an adult patient for gentamicin would be like Q8 hours, right? Because they have much better kidney function, they'd be able to process it much more easily, okay? There's something to consider there. But also look at things like, urine pH. You're looking at things like, that can affect reabsorption or excretion of the drugs. Also keep in mind, how do you determine a neonate's renal function? We have a good equation for that. Not for the neonates, not so much, because again, especially think about the first couple of days of life, their creatinine is, you think it's going to be falsely high or low? Yeah, so I'll talk about that in a second. But yeah, so initially, when they're first born, you're actually going to be measuring falsely high because you're actually measuring the mom's serum creatinine. Over time, that gets cleared out and eventually will go back down. But more often than not, we use urine output, right? That's the best way we have to measure actual good function of the kidneys. And so typically, we're looking for at least 1 ml per kilo per hour for neonate. And then sometimes it can be much higher. That could be 4, 5, 6 mLs per kilo per hour. So they have a large volume of urine based on their weight when they're first born, especially when they're initially doing that diuresis kind of phase there. But those are things we want to look at because we don't have a really good equation to really determine that function, but urine output's a good one that we can use for that. But keep those things in mind because, again, if you start to see that urine output go down and you have a drug that's renally eliminated, like gentamicin, you need to keep that into account because otherwise those levels can jack up and then all of a sudden they have ototoxicity, nephrotoxicity can develop even further from there, right? Anyway, so as I mentioned, that first month of life should be falsely elevated, though. But also think about where does creatinine come from? From the muscle breakdown. What do we say about muscle mass in neonates? They don't really have a whole lot, right? I don't know if any like bodybuilder babies coming out or anything like that, but they usually don't have a ton of muscle mass. So because of that, creatinine is going to be kind of falsely low because they just don't have a lot of muscle to produce in the first place, which is why we don't really use creatinine clearance equations for especially the neonatal period. Once they get a little bit older, their creatinine will kind of stabilize out. That's when we can start to use things like the Schwartz equation is a common one we use for pediatrics. But just keep in mind, you can't use that Cockcroft-Gault equation, which is great for adults and pediatrics because, again, the studies were not done in the populations are different enough to where the same equation is not going to give you the right answer for those kids. Okay. Anyway, just looking at renal function in terms of when the kid was born. So obviously premature kids, they usually weigh less or more than their full-term cohorts. A lot less usually. I mean, like think about this, preterm kids, less than 1,500 grams, right? It's less than 3 pounds, right? Some kids less than 1,000 grams. Again, this is really important as well because, again, how many grams go into a kilogram? 1,000, right? Kilo, 1,000. So keep those things in mind because when you're measuring these NICU kiddos, they're usually measuring them in grams, especially if they're premature like that. But if you're doing conversion and you're looking at milligrams per kilogram, if you screw up that conversion, you're going to get yourself in trouble, right? I have a kid who weighs 996 grams, and I'm trying to look at that, and I say, okay, well, this is dose 1 microgram per kilogram. Okay, so I'm going to give them 996 micrograms. Yeah, you're cooked, right? You don't want to do that. So in those cases there, you want to make sure you're doing your conversions right, because it's super, super important you be careful with those conversions. Anyway, so if you're looking at a premature child in terms of renal function versus, say, their full-term cohort, and looking at the GFR, if you were to actually directly measure it, you'll find that even though we know they're going to be diminished, right, in the firstborn, we know they're going to be underperforming, even by the time, say, they're 2 weeks out, they're still not even at the level of where the full-term kids are. So again, it's going to take them a lot of time to really kind of catch up there, and so that's why you want to look at that gestational age in terms of helping you to determine how frequently you need to give a drug. Okay, and so take them time to catch back up. They will eventually, but again, just because a kid is 2 months old doesn't mean that they are developmentally 2 months old as compared to someone who's full term. Anyway, looking at GFR, you can see here the early parts it's going to be pretty low, but by the time they're 6 months to 3 years of age, like they're going to be pretty close to adult levels. But again, we're using the Schwartz equation to measure that. We're also looking at urine output as being a good surrogate for telling us how good the urine output is, or how good the renal function is. And just as an example here, looking at the half-life, looking at a neonate less than 1 week old, 3 to 11.5 hours for gentamicin versus, say, an adult patient, 1.5 to 3 hours. Okay, the half-life is so different because they don't have the quantity and quality of the nephrons in order to clear that drug out. Okay, the actual filtration rate is going to be that much lower during that first early period of life. Anyway, looking at tubular secretion and reabsorption, obviously this is going to be dependent on the renal pH. It's going to depend on the drug you're dealing with. There's a lot of different factors here. But again, this is already taken into account when you're looking up stuff on Lexicon. They will factor this in for you. So looking at diversity in these drug responses, like, well, why do some kids respond differently? There's a lot of factors that go into it. So one, looking at their developmental where they're at in terms of development, like how premature they were. You also have to consider like genetic factors. You also have to consider, what sort of issues are being born with in terms of if they have congenital heart defect. Was the mom on abusing medications throughout the pregnancy? And again, it could differ. So for instance, a mom who is abusing cocaine throughout the entire pregnancy versus opioids, it's going to have a different sort of picture there, right? Depending on what kind of effects you can see from that. Okay, because again, think about it. Cocaine. What does that normally do to things like blood vessels? Usually constricts it, right? So again, it can lead to issues there. Maybe you don't have good development of tissues because you're vasoconstricting all that stuff in the fetus for that period of time. Opioids will have a different kind of picture there. So just know there's differences, and a lot of these things will factor into how a patient actually responds to that dose. But as an example, remember keeping in mind things like CYP2D6 metabolism, right? Some of this is actually based off of your genetics, based off your heritage, and determining, well, how much of an enzyme are you actually going to produce there. And so I've talked about this example before, but if you remember, codeine itself, what does it get turned into? Morphine, right? So you'd have codeine getting turned into morphine, and that's really the active component there. Well, if I have someone who does not have a whole lot of that CYP2D6 enzyme to convert it over, what's the therapeutic effect going to be? It's not going to be very good, right? So again, you can have someone who has a low level of CYP2D6 metabolism, give it to them, they're like, well, this drug's not very good. I don't get a whole lot of analgesia from this. Versus someone who's a ultra rapid metabolizer, they're getting a lot of effect from it, right? And remember, we had these kids who were getting, had OSA, right? So these really big and large tonsils. They're getting them taken out, right? What happens after surgery? Hair's going to get swollen. It's going to be a little edematous, right? And then you're giving them all this morphine inadvertently. You're converting all this drug over to morphine. What does that do to your respiratory drive? Blunts it. So even though they're swollen and they're closing off that airway, they're not detecting it because their brainstem is being blunted from the opioids, the morphine, and guess what? Stop breathing, they die. So that is again why you don't see codeine being used in these patients anymore. But again, you have to think about the which patients are going to be more likely to express this or not express this, as the case may be, right? And so it can depend on where you're from, it can depend on your family history, it can depend on a whole lot of different factors there, right? So again, how are we going to be dosing pediatric patients? What's the most common? Weight-based dosing, right? So for the most part, you will not get yourself into trouble by using weight-based dosing. What's the problem with using age-based dosing? Yeah, it assumes that all kids are built the same, right? Every 2-year-old's built exactly the same, right? Every 6-year-old's built exactly the same. That's not the case, right? Just to give you an example, my one of my kids' cousins, so my kid's almost 3, my older kid is almost 3, and her 2-year-old cousin came by, and my girl's big for her age, like she kind of dwarfs a lot of the other 2-year-olds around the park, but her 2-year-old cousin comes up, and she's almost 3, and her 2-year-old cousin comes up, and he's as big as her. Right, so again, you can find these kids are very, very different in terms of their development, how big or small they are, and so based off of that, the age-based dosing can be fraught, right? Especially if you think about things like pediatric obesity, things like that, underweight kids based off of comorbid conditions. A lot of this can be playing a role here. So because of that, we don't like to use a whole lot of age-based dosing, even though it is convenient, it's easy to memorize, etc. But we try to avoid that if we can. I said body weight dosing is much more common as you have become accustomed to. Again, keep in mind though, look at your dosing that you run into. Look at whether it's micrograms per kilogram, whether it's milligrams per kilogram per day, divided twice daily. Be very careful when you're looking at that. And in fact, I believe on your test, there's going to be some dosing calculations on there because we're covering it here, right? You guys are all very well versed at this by now, right? So I don't need to cover it a whole lot because I know you're all experts at doing drug dosing. Okay? Don't worry. You'll be fine. But now you're starting to regret the tie clip, aren't you? It's too late. I'm already wearing it. I'm not getting it back. However, the math's pretty easy, so don't fret too much about it. Anyway, but keep in mind, this is good. But I just had an instance just the other day. We had a kid who was going to surgery. The kid was 3 kilograms. And so the anesthesiologist was writing for the PACU orders, and typically we'll write for fentanyl, 1 mic per kilo or a half mic per kilo, Q5 minutes for 3 doses, PRN pain. Right, that's a pretty common PACU order you'll see for kiddos. And so the anesthesiologist, and again, this is the anesthesiologist, not just like a CRNA, right? You just can't say like, well, the doc is going to get it right every time. Not really, right? Anyone can make a mistake. So the anesthesiologist had written for they had meant to write for 3 micrograms of fentanyl because the kid was 3 kilograms, but instead she didn't check the box that had mics per kilo. She didn't change that, and so instead she wrote for 3 mics per kilo per dose. It's the difference there. So instead of getting 3 micrograms, the kid was going to be getting 15 micrograms. Or I'm sorry, 9 micrograms, which is a much bigger dose than they should have been getting. So based off that, I call them up. Hey, this seems like a pretty big dose. Is that what you want? Oh, that's not what I want. Right, change it over. So be very careful with your dosing units, especially with these computers. It's easy to get into the false sense of security that the computer is going to save me. Not always, right? You still have to factor in the human component there, and humans are prone to error, right? More often than not. So anyway, things to keep in mind. Again, this is nice because it will kind of mitigate the differences in weight just based off the age of the child there, and this is the most common thing you run into. Now, again, you're going to find we have an increasing incidence of overweight children. So again, you have to keep some of these things in mind. As they start to get up close to those adult doses, and you're starting to get above adult doses, just cap it off, right? You don't want to go above that, above and beyond that. And very frequently, you'll find that your drug references will give you max doses you don't want to exceed, okay? The other way we could do it is body surface area. You remember where we talked about using this pretty frequently? Used a lot for chemotherapy, right? So if you work with oncology, you'll find this being used very, very frequently for those patients there. And again, using body surface area, there's a lot of different equations that are out there. So whatever one you use, just be consistent with it. But it factors in both the weight of the patient, but also what else? The height of the patient as well, right? And again, is height easy to get on a patient, a pediatric patient? It can be potentially difficult, right? So especially if you're doing like an infant, they want to kind of curl up into a ball. To get them stretched out to actually get an accurate height can be difficult, especially if they're screaming, crying. You know, getting a 2-year-old to stand still for more than a nanosecond, exceedingly difficult, right? So again, sometimes getting an accurate height can be hard, but hopefully you get an accurate one, and that will then be factored in along with the patient's weight. So that way, even if there are extremes in height or weight, they tend to balance each other out. And so this is probably one of the safest ways to do it, but it's a little bit more labor intensive and only usually done for drugs that require kind of the most kind of the high risk drugs. So that's why you see a lot with chemotherapy. Most of your 90% of the drugs you're going to deal with, 95% probably, will be milligram per kilo dosing for most of these kiddos. Anyway, so again, looking, and I'm going to let you go on a break in just a few seconds here, but making some considerations about IV drug dosing for these patients here. You have to think about things like volume, right? The volume of drug you're actually going to be administering to these patients. So if you think about a neonatal patient who maybe only weighs a kilogram or 2, giving 5 mLs of volume may not seem like a whole lot, but if you're giving multiple doses of drugs a day, if you're giving it, say, continuous fluids along with that, you can find that you can overload the patient with too much volume, right? So typically the concentrations we're going for are what? Probably want higher concentrations of medication. That allows us to limit how much fluid we have to give, which is useful, okay? Now, what can happen if I give too concentrated of a drug into a vein potentially? You can see things like extravasation. It can cause thrombophlebitis. So there are limits to how concentrated of a drug you can give, but there's ways to get around that, right? So again, when we talk about peripheral versus central access, what's the difference there? Peripheral means I'm giving it like, you know, in the arm or somewhere distal to the central blood flow. I'm giving a central access. That means what? It's going right into the vena cava, right? So again, it's getting right near the heart as close as you can to that venous flow. The benefit of that is what? It's going to get diluted out very easily. Yeah, hopefully the access is correct, so that way you have you don't have to worry about extravasation so much. But it gets diluted very quickly, right? So I can give higher concentrations. I can give drugs faster in some cases there. And again, you don't have to worry about things like, if you imagine a vasopressor, like if I give norepinephrine, right? Patient blood pressure is low and I want to get it up with norepinephrine. If I give them a vasopressor peripherally, what's going to do all those blood vessels is hitting early on? It's going to clamp them down, right? And again, that's not what I'm shooting for. If I can give that centrally, I can give a whole lot more, give it faster, etc. And I don't have to worry about causing that effect there. Okay. Things to consider. Also think about things like if you need to measure labs on a patient, right? You're doing blood levels to measure gentamicin or something like that. You think how much blood are you actually drawing off these patients here, right? Because again, you can significantly affect their hemoglobin hematocrit for some of these little sick babies that you're having to do a lot of blood draws for. So you try to pull those together so you can use the same sample for multiple tests. But those are things you have to always consider there as well, right? Anyway, we're actually running these. It's very important that you don't just hang things to gravity in a lot of cases. You need to use things like infusion pumps. We have things like a syringe pump here that's good for small volumes of medication to be given. And again, the nice thing with this, it has libraries built into it, so it has concentrations that are defaulted, has dosing limitations put on there, so you can't just give crazy high doses or drugs too quickly. And so again, these are very nice because it will allow for you to give the drug more safely to a patient. Now, you as the PA, do you think you're going to be programming the pumps very often? Probably not, right? But again, if the nurse comes up and they're like, hey, I can't actually run this on the pump, what's going on here? You at least want to be able to look at some of these things and know, okay, well, what's the concentration we're giving? What's the dose that we're giving? What limits are we hitting here that is preventing this medication from being run? Because again, if we decide, oh, we're just going to run it off the pump, we're just going to run it without the library, any issues with that? Yeah, you can run into some big issues. You had some problems where the nurse is like, oh, well, it's fine, whatever. I'm just going to run it off the we call it guardrails. That's what we run it off the guardrails. We've seen some big errors happen because of that. So you may not be the actual person turning on the pump and actually hooking it up, but you just want to be able to help troubleshoot some of the issues you run into, especially if you're like the one provider there dealing with the nurses and whatnot. Like you need to be able to help out these things. But this is one way we can give accurate doses just like we want to. And then as far as oral administration, what did we talk about before in terms of how we're administering these doses orally? How do we measure the doses? You want to use your dosing syringes, right? So again, this should be standard nowadays, but because again, what was the problem with using teaspoons and tablespoons? Depends on where you get that teaspoon or tablespoon from, right? A teaspoon is typically how much volume? 5 mLs. Tablespoon is how much? 15 mLs, okay? Good to know that conversion there. But again, if I go to IKEA and I get one of their Swedish spoons, it may not be the same as if I go to Walmart and I get an American spoon, right? So again, spoons come in all different sizes. I say it's a tablespoon, but the volume can actually be pretty different there. Even those cups that come with it, I actually were given medications to one of my children. I poured it out into the thing that said 5 mLs, and then I drew it up in a dosing syringe, and it was like 6.5 mLs, right? So again, dosing syringes are always going to be the most accurate way to get the right dose into the patient, okay? And again, make sure you tell your patients, hey, when they get it from the pharmacy, make sure they get those dosing syringes. That's going to help them out in the long run. But also think about things like drug-food interactions. Kids are oftentimes drinking a lot of milk, right? Calcium binds up a lot of drugs. You have to think about that. Think about things like inactive ingredients like dyes. Like kids can have dye allergies, and so you have to use dye-free formulations, right? Because can every kid take a tablet? No, someone's got to take liquids, or a lot of them have to take liquids, and so you have to consider things like that. Imagine if you have a kid who's on a ketogenic diet. What kind of kid would be on a ketogenic diet? They have really difficult to treat seizures. So again, we have to consider all forms of carbohydrates that they're getting. And a lot of those liquid medications contain a lot of what? A lot of sugar, right? So all things you have to consider here when you're dealing with some of these more complicated patients here, right? Anyway, so again, always make sure you get the most up-to-date weight you can possibly get. That's super beneficial there. Always double check your references. Always look it up. And just make sure that if you're counseling these patients, talk to their level. And again, if they're too young, then obviously talk to the patients on their level. And again, some of these parents or caregivers, are their levels much higher than a child in some cases? May not be, right? So again, you need to make sure you really kind of bring it down to the appropriate level so that way they understand how they're going to be getting the medication, how long they're taking it for, how to administer it, etc., right? All very, very important points. Okay, so remember your 4-2-1 rule for fluid dosing, right? So if I have a 12-kilo patient, what's their volume, their maintenance rate of fluids? So 4 mLs per kilo for the first 10 kilos, 2 mLs per kilo for the next 10 kilos. So a 12-kilo child to get 44 mLs an hour. right? The maintenance fluid rate. What's their bolus dose? 20 mLs per kilo, right? So 20 times 12, 240 mLs. You'll get better at this the more you practice it. Obviously, you will have the help of scratch paper. You will have a calculator, I believe, on the test. You'll be okay, right? Don't stress too much about it, but practice, right? This is easy stuff, and you're going to do this all the time. If you work in pediatrics, and if you can do this quickly, like on your first day of your peds rotation, you're going to look like a rock star, right? So you can just get comfortable with doing this stuff. Again, I don't think I have any questions here on this, but just remember, if a drug is ever expressed as a percentage, remember how to convert that into milligrams per ml, right? Because when you're doing your dosing, you want to know the concentration you're dealing with. So remember the rule. You take the percentage, you move the decimal place 1 over to the right, and that will give you your concentration in milligrams per ml. So a 1% solution of lidocaine turns into how many milligrams per ml? 10, right? You move the decimal place 1 over to the right. If I have D50, dextrose 50%, how many milligrams per ml of dextrose is that? 500. Move the decimal place 1 over to the right. It's easy, right? So just remember that's how you get to your dose. Because now I know that D50 is 500 milligrams per ml, and I want to give my patient a dose of 0.5 gram per kilo. I can figure out that dose a lot easier, right? Because 500 milligrams is 0.5 gram. So if I need to give them 0.5 gram per kilo, they weigh 10 kilos, and 10 ml, right? You'll be able to do this over time. Practice with it, though, right? But again, the concepts are the same here. Double check me if I got anything wrong. I'll correct it on the YouTube posting. But anyway, those are things you want to keep in mind. So any questions on that so far? All right. Let's do a 10-minute break. We'll come back and continue on. All right, guys, ready? I'm going to continue on. All right, any questions on the first half? Good review, hopefully, for most of you, right? Maybe a good review. Let's see. So moving on to the opposite end of the spectrum, dealing with the geriatric patients, right? What do we consider to be geriatric? 65 and older, typically, right? We do know that our population is aging, right? So as the boomers are starting to get there, you know, one of the things I'll talk about is like temperature regulation, how that typically is more difficult for older patients. And so you ever like go to your grandparents' house, like what's the temperature usually like? Hot, so hot. And I finally knew when my parents were getting old because I went to their house. And I was like, oh my gosh, why is it so hot here? Why is it like 78 in your house? And they're just like, oh, we get so cold now. And I'm just like, oh, mortality is looming. No. But anyway, we're all going to get old, right? No one's getting out of this alive, unfortunately. But looking at this, you're going to find that probably the grand majority of the patients you're dealing with, unless you go specifically into pediatrics, are probably going to be geriatric patients. And a lot of how we've talked about medication so far has already kind of been alluding to, okay, well, when you have these older patients, here's how you need to look at dosing strategies, right? Here's how you need to look at these adverse effects and et cetera. And so just kind of briefly kind of going back through and looking at some of the highlights of things to consider when dealing with these geriatric patients, think about the medications we already talked about. And I'll talk about some specific drug classes in a little bit, but when we talk about things like, you know, orthostatic hypotension, we talk about things like mental status changes like dementia, think about how these medications we've already talked about can be playing a big role here, right? And so, you know, assessing these patients is super, super important, right? So again, making sure that you're determining what is their actual function, not only in terms of kind of what can they do right now, but specifically like how are medications affecting this is another big question I think you should focus on when you're thinking about the medication profile here, right? You need to focus not only on, you know, what their activities are, but also like quality of life issues, right? You know, if they're having to get up and go to the bathroom all the time, or if they are not able to do the things they like to do, like going golfing or whatever the case may be, you need to kind of focus on all these different aspects here. And unfortunately, a lot of times you're going to find that a lot of psychosocial issues go sort of undertreated in all these older patients here, right? You know, these patients probably, a lot of them end up suffering from depression, and people just don't necessarily take the time to really dig into it and make sure it's adequately treated there. And again, take advantage of the interdisciplinary team, right? So again, especially when you're in the hospital and rounding on some of these patients here, make sure that everyone's perspective gets heard, right? Because you want to make sure that, because everyone's got different priorities, right? I'm obviously focused on the drugs. RT is obviously focused on the airway issues, right? Nutrition is obviously focused on nutrition, right? So by everyone kind of getting their perspective in, and you being the central provider, being able to kind of take in all these information and say, okay, well, let's base a plan based off of these different facts here. You can then act on that stuff. But again, always reach out to your experts. Always get that additional help there, okay? We'll talk about some other issues that in a little bit. But obviously look at not only just their basic activities, like can they get up and out of bed, can they actually shower themselves, but look at some of the more advanced things. Like also think about activity and what they can and cannot do over a period of time, right? So for instance, say you start a new medication for a COPD patient, and ask them, okay, well, can you go out and get the mail? When do you start to run out of breath? Can they actually, once you start a new medication, can they then walk out to the mailbox and back without getting winded? These are things you want to kind of be thinking about in terms of how efficacious your medications are working, or potentially how big a side effects they're introducing for them as well. Okay. So looking at things like the nutrition aspects of things, think about one, like can they even swallow their medications, right? Do they have Parkinson's and they have dysphagia now and they can't swallow tablets anymore? You have to consider, okay, well, let's switch all your medications over to liquids. Are there even liquids available for half the medications you're on? Maybe, maybe not. Maybe I need to switch over to transdermal patches. Maybe I need to do X, Y, and Z. Things you have to consider, right? Think about their dietary intake, right? We had an event where we were talking to a group of Parkinson's patients just recently. It was really interesting. If you remember when we covered Parkinson's, what's kind of the cornerstone of therapy for that? Levodopa, carbidopa. Remember, I talked about a dietary interaction you have to consider. Protein, right? And so it was really interesting to get to talk to some of those patients and then being like, oh yeah, I have to make sure, if I have to make sure I don't eat my eggs at the same time as I take my Cinemet. Otherwise, I end up finding that I start to have a hard time getting around, right? Because remember, Parkinson's issues, they can't really initiate movements. And so it was really cool getting to see, like, oh yeah, she can't eat her eggs at the same time because of protein interactions, and it's really neat when you get to make those connections in actual real life patients, right? So think about that, especially when you're going on rotations, and be like, oh yeah, that links back to exactly what we talked about in Pharm all those years ago. Assuming you don't dump everything as soon as you walk out of here. But think about things like, other concomitant disease states, how this may be affecting their appetite or their ability to absorb drugs effectively. Think about multiples of medications that all are going to affect the GI tract, specifically constipation being a really big issue here. So if you have a patient who, say, is on a calcium channel blocker for their blood pressure, what did that cause? Cause constipation, right? Specifically just with the GI tract. Remember, you're blocking calcium influx and you're decreasing the activity of that smooth muscle. Imagine they're on opioids for chronic back pain. What does that do to the GI tract? It's going to make it worse, right? And imagine they're on, say they're on calcium supplements for osteoporosis. Calcium is going to slow that down too, right? So again, you have multiple medications that are all affecting that. And again, you can find that this can be a significant effect on their quality of life. If you're constantly going around feeling bloated and having abdominal pain, like, it's no good. And in fact, my wife, she did her pain management residency. This is her second year residency. Had these patients who are, not really communicative anymore. They're end of life. They're, on palliative care, and but you could just tell, like, they just weren't comfortable, right? Their pain medications were kind of going out of control, and you just tell, like, their vital signs just weren't normalizing out. They're like, man, what's going on with this patient? They just don't look comfortable. Giving them an enema, a massive bowel movement, and guess what? Vital signs start to kind of normalize out. Patient looks better. Pain meds are starting to go down, and because don't underestimate the value of a good poop, right? Another takeaway you can take away from my class: never underestimate that. Whether you're dealing with an infant who's getting on the solids, or you're dealing with an elderly patient. In fact, in some cases, you kind of consider them kind of equal kind of patients, right? Similar issues, but this is important, right? And again, think about financial access. Think about the ability to even prepare food. A lot of times patients will just kind of fall back to whatever is easy for them to make. You might find that they just eat a lot of cereal, right? Because they can pour cereal and pour milk into it, but they can't necessarily cook a decent meal for themselves, right? All things to look at. You want to ask about kind of a detailed recall of what they're ingesting, not only in terms of food, but also liquids, right? So do they drink coffee? Because caffeine could be playing a role in their medications. How many alcoholic beverages are they imbibing? Do they even drink any water? Things like that, right? What other drink that elderly patients like that may affect their drugs? Grapefruit juice, right? I always wondered, like, man, why do my grandparents, like, they were kind of country folk, and they had a big grapefruit tree. And I'm just like, why do we have to grow this grapefruit every single year? This stuff tastes terrible. They loved it, though. Why is that? Yeah, their taste buds are going out, right? And they just need something strong to really kind of kick their taste buds in the butt to get some flavor going. So I was like, this stuff's terrible, but they loved it. But again, that could play a big role with their medications, right? Think about things like their vitamins, their supplements, etc., because these can all be playing a role with causing drug interactions, could be affecting it could be causing side effects that lead to other drugs needing to be started to treat those side effects. A lot of issues there, right? If you can't hear me, just let me know. I'll pause it for a second. Anyway, but again, ask about vegetables they're eating, ask about fruit intake, ask about all that good stuff. I remember when I was on my first rotation, I'm going to try to speak extra loud so the helicopter goes away. My first rotation, it was in Palaca, Florida, Probably mentioned this before, but anyone familiar with Palaca, Florida?
Yeah, where
This is like, these are salt of the earth kind of people, right? These are backbone of America. Simple people, right? But I was basically working for a Coumadin clinic. It was like a family health care center. And we had a pharmacy-run Coumadin clinic, right? So we were doing warfarin dosing. And, you know, thinking about warfarin, what's a big role that food plays there? Vitamin K. What kind of food has a lot of vitamin K in it? Collard greens, spinach, kale. Guess what they're growing in their backyard? All that stuff, right? So again, you had to take into account, like, okay, well, what's their diet like? You know, are they getting a ton of kale and collard greens, all this kind of stuff? And again, is it that you had to say we can't eat any of that stuff anymore? No, you just have to be consistent with it, right? You have to make sure. A lot of times, if they're on a fixed income, like they're growing that food because that's their diet, right? That's what they, not because they like to do it, it's just because that's where they get their food from, right? Not doing. We're trying to be organic here. Like, no, they're like, this is like the food I grow that I can eat to survive, right? And so those are all things you have to start thinking about, right? And how it's going to be affecting their medications there. Now, again, when you ask a patient about their alcohol intake, and I'm probably speaking of this a little hypocritically now that I'm getting bottle openers for my students, but when you ask them about alcohol intake, like, what do you ask them? What do you say?
how much do you drink and what do you drink?
Yeah, okay, so you ask how often, how much, what do you drink, right? All play a role there. So, for instance, you have someone who really likes their beer, right? What's a big issue that can happen if you just get the majority of your calories just from beer? Anyone know? Yeah, you can get thiamine deficient. You get a lot of deficiencies of a lot of water-soluble vitamins. What else? You get diabetes, yep, because there's a lot of calories in beer. Also, if you think about there's not a lot of sodium in beer. So you need to develop what they call a beer potomania, or they actually develop hyponatremia because they get most of their calorie intake and their fluid intake from the beer.
What causes the beer belly? Is that just like because they're insulin resistant now and now they're getting all the essential?
It's just there's a lot of carbohydrates. If you think about, you know, not only the carbs are in just the beer itself, but the alcohol itself has calories associated with it as well. Yeah, it's just a lot of extra calorie intake. It's very easy to get a lot of calories in without really realizing it. I don't know if anyone's looked up calorie content for some of these craft beers that are like 9, 10%, you know. It's like, it's liquid bread essentially, right? So, in fact, if you ever go to the Orlando Brewing Company here in downtown, I guess south of here, but the guy does like a really fun tour. You know, you get to go around and get to see their brewing process and stuff. And he's like, yeah, it's liquid bread, like, and that's such a good way to think about it, right? With all those carbohydrates and stuff. Yeah. So just like people eat a lot of carbohydrates and bread and candy, you think get a big belly too. Yeah, just associated with beer. Anyway, but so again, you want to ask how frequently, right? So how many nights a week, you know, how many times a month, etc. But also, like, when you say, like, well, you know, patient tells you, oh, I drink 2 beers a night. Yeah, how big is a beer, right? So again, if I get a big stein full of beer, that's 1 beer for me, right? Maybe. Or if you think about it, the tall boys, the normal size, you know, think about, you know, I have 1 drink of whiskey a night, but it's a handle, like.
We actually had a patient. He said he drinks 2 cocktails a night,
Mm-hmm.
and we asked, okay, what do you put it in? 2 big Yeti cups. He's like, I drink 4.
There you go. See, so yeah, start early.
Yeah.
But anyway, so these are questions you have to ask, right? Because again, everyone's going to have a little bit different interpretation. Again, are people necessarily always going to be straight with you when they're telling you things about like their I'm trying to think of the word, their vices? Not necessarily, right? So again, sometimes you have to consider they may not be giving you the full story, but all questions you have to ask about, right? Because again, if you have a patient who's having, you know, accelerating dementia or Alzheimer's or things like that, think about how the alcohol could be playing a role, not just their other medications, but all that can be factoring in together, right? You know, look at things like weight loss or weight gain over time, because it would be indicative of either too much calories in or maybe not enough activity, or if they're losing weight, could be an issue of malnutrition, etc., right? All things to think about. Laboratory testing. So what kind of labs would you get? Say you're assessing a geriatric patient for the first time. What kind of labs would you want to get for them? Kidney function. How do you determine kidney function? BUN and creatinine. Good. Right. So BUN and serum creatinine. What do you get that on? So a CMP, right? So it's a complete metabolic profile. If I want to go more simple than that, I didn't have the money for it. You get a BMP, right? So a basic metabolic profile. What comes on a BMP? Not a BNP, right? Keep that in mind. People can mishear that. BNP is something you get for a CHF patient, right? So let's say you're just getting a BMP. So we got sodium, potassium, you get glucose, chloride, bicarb, BUN, not BUN, and serum creatinine, right? You get a lot of information just off of basic Chem 7, right? So it's good to know, right? You can look at electrolytes, you can look at glucose, you can look at renal function, you get a lot of good information right there, okay? With a CMP, what additionally do you get? Liver functions, right? Just useful. What else you get? Yeah, you usually get a few extra electrolytes. You get like a calcium, mag, phos, things like that, right? So that's usually going to be in your complete metabolic panel. So that's good, right? So there's good information to have there. What else might you want to consider looking at? CBC could be useful, right? Because what does that tell us? Yep, so we can look at specifically those, look at their white count, see if they maybe have some kind of inflammation going on, have an infection, look at their hemoglobin hematocrit, if they're coming in complaining of fatigue. Maybe they're anemic, right? So these are all things you want to consider looking at. Additional things you might look at are lipid panels, right? You want to look at their A1C, which tells us what? Yeah, so you're going to look at average glucose over the past 3 months or so to see, maybe that you're assessing them for diabetes, et cetera. And UA can help us out as well, if they're spilling a lot of protein or spilling glucose in the urine. So again, these are additional labs you might want to get. All these are very useful for helping us to not only determine kind of where the patient's at baseline, but also kind of how they've changed based off the medications that we're offering them, right, or we're giving them. And again, one of the big things I always ask about whenever kind of assessing a patient based off their labs, what did they have previously, right? Do they have any previous results that we can look at? So for instance, what's a normal serum creatinine? Like 0.6 to 1.2, like somewhere in that range. So if I have a patient who comes up and their serum creatinine is 1.5, I can say, oh, that looks elevated, but is that elevated for them or is that just their normal? That's why I need to have previous labs to compare that to, right? I do this a lot as a toxicologist when I'm on call for the poison center. I have a patient who they call up with an EKG and the QRS is prolonged. Well, I don't know if it's because they have a right bundle branch block, because of they may have had a previous MI or something like that, or it's because of drug effect. So I say, well, do you have a previous EKG to look at? And if that's prolonged there, then I know that's just normal for them, right? Versus it's a new change. So deltas are what you're looking for. You're looking for changes over time as well. So if I start up a new anti-diabetic medication, start my patient on glyburide, what am I going to look for in changes over time on? I'm looking for hypoglycemia, so Kim7 can help me with that, but more importantly, long-term efficacy, A1C, right? So again, maybe I can have the patient, he's like, I'm going to trick them. I'm not taking my glyburide, I'm just not going to eat any carbs. I'm just going to, maybe I'll take a dose right that morning. You check their Kim7 or their AccuCheck and glucose comes back normal. Like, wow, this drug's really working. Check their A1C, comes back at 9%. Okay, they're not really taking it, right? So again, factor all these things in when you're assessing these patients and looking to see how your drugs are working over time, right? Anyway, these elderly patients are going to be on a lot of drugs. Polypharmacy is more the rule than anything else. And why is that? Why do you think that is? A lot of comorbid conditions. Yep. What else? Multiple providers. If you're seeing all your ologists, so you got to see the endocrinologist, seeing your rheumatologist, your pain management specialist, your psychologist. You're seeing all these different people. Guess what? All of them might be prescribing medications for you. Say for instance, you have, you're going to see somebody, you get your ADHD, you diagnose with adult onset ADHD, and they give you amphetamines for that Adderall, and then you go to see your PCP, and they're like, oh, you're hypertensive now. What are they going to give you to treat that? Antihypertensive now. So you're treating side effects of one drug with a new drug, right? So again, you can see how polypharmacy can start to cycle up and ramp up pretty quickly there. And again, patients are living for longer, so you're starting to see this more and more commonly. Think about like your HIV patients, right? Remember back in the 80s, how long were they expected to live? Not long, right? However, nowadays, they have a pretty normal lifespan. So now they're getting more of these chronic conditions, a lot of them being induced by their medications they're on, and so now you're having to treat that. Medication lists tend to expand pretty exponentially in a lot of cases. But, think about things like hospitalizations, right? The people, when you get about to discharge a patient home, where you're normally like, let's go ahead and stop this medication. No, usually you're going to get extra stuff added on. For most of your patients that are getting discharged from the hospital, right? And and again, we try to teach you guys to be like, the general practice, family practice, or PA. It's kind of the frame we go with a lot of cases. You might be the central node for this person's care, but again, are you going to be likely to stop another provider's medications they've started on your patient? You're not going to want to, right? Because again, it's a professional courtesy. But if you see something wrong, what are you going to do? You should call them, right? A lot of people, you're busy though. You got to see 30 patients a day. What if they don't use a patient portal? What if you got, your provider, their cardiologist works for a different group and they don't use the same patient portal? Some information. Ask the nurse to call me. All right. So again, you have to think about ways to get around this stuff, right? Because again, you're going to be busy. You're going to have limited time, limited bandwidth. How are you going to get around that? Because again, the thing that a lot of people will do is kind of fall back on that default. They're like, well, it's someone else's medications they ordered for that. I don't want to touch it. And so then you're stuck with this patient with 12 to 15 different medications they may not necessarily need. They may need it, may be totally appropriate, but unless you have that conversation, it's hard to say, right? So you can always think about that. If you see something wrong, though, you need to say something, right? You need to try to at least ask the question because it could be appropriate, but unless you ask the question, you're never going to know, right? Anyway, but again, with this polypharmacy, you're going to see a lot of adverse drug reactions. You can see especially a lot of big issues with things like orthostatic hypotension. You're going to see mental status changes potentially that could lead to falls. Once they get a fracture, that can be a really big problem. That can lead to significant effects on quality and quantity of life for those patients there. And not only that, but the more drugs you're on, how likely are you to be compliant? Not as well, especially like Alzheimer's or other dementia and other things like that. It can be very, very difficult. I can't even take a multivitamin every single day. You expect these patients to take 12 different medications 5 times a day? It's hard to do, right? Very hard to do. Other things that factor into this, right? So say, for instance, you're working in your clinic and you have this drug rep come by and they're like, hey, check out this new NSAID. This thing is awesome. Come out to lunch. I'll tell you all about it, right? Very nice lunch. Go to Ruth Chris. Come back and like, wow, that drug is great. Love that drug. Prescribe for your patient. Guess what? Insurance doesn't cover it. Costs $1,000. They gonna buy it? You're gonna get that medication? No, not gonna do it, right? Motrin, would that work just as well? Probably. Right. So again, think about that. Not that you guys are gonna be susceptible to big pharma. A lot of times you're gonna start to see some of the stuff go away. They really cut that out for pharmacy. We used to have like drug dinners all the time. It was amazing. No longer, right? No longer. They cut us off of the corporate teat. They said, no longer. You will not be influenced by these pharma companies. So I said, okay. I don't think I recommend drugs any differently. I just get a lot less delicious food out of it. So, but regardless, though, you have to think about things. If the easy stuff works, if the cheap stuff works, just stick with it, right? There's no reason to use a brand name drug just because it's new, right? Patients may come in, right? Because again, they are susceptible to that marketing. They'll see this new commercial that came out for this medication. They look at all these elderly people. They're having the greatest time of their lives with this new drug, and you're like, but it costs like $12,000 a month, and they're just like, that's what I want. But that's the questions, right? So you need to be able to come back and say, well, that's fine and all, but this medication works just as well, and it costs cents for a tablet. You know, to be able to have that persuasive kind of conversation there. But think about things, decreasing compliance, like their mental decline. Think about visual impairment can be a big problem. I had this one patient when I was on rotations, and she was blind as a bat. She basically couldn't see anything farther than a few inches in front of her face, and she was getting a refill of probably 12 medications, right? And so she had this system where she would have different colors and shapes on the top of the bottles in order to tell her what medication was in there, because she couldn't read the labels anymore. And so I said, there's no way you actually have this all memorized. I can't even look at this and make heads or tails of it. And she's like, no, test me. And so she had one that had like a purple triangle on it. So I showed it to her, and she's like, holds it up and like, oh yeah, this is my metoprolol. Sure enough, I was right. What about this red star? Oh yeah, that's my lisinopril. I was like, she had it down, right? So her mental faculties were sharp as a tack. However, vision just was poor, right? So again, they need help. Need some kind of system to help them make sure they're going to be compliant there. Think about things like decreased IV access. If they get stuck all the time, they're going to be hard sticks. If they're dehydrated, they're not going to be able to get very good access. You know, obviously there's ways around that, but these are things you want to consider there. And just patient willingness to adhere to treatment, right? You know, if they're old enough, they may be like, I'm all right, I'm good, right? You know, these side effects, they're not really helping me out at all. I get an extra few months of life, not a big deal for me, right? So again, think about where they're at in terms of their journey. Because again, a lot of times towards the end of life, we're not focused necessarily on the quantity of life, but the quality of life, right? So again, if their blood pressure medication just makes them dizzy all the time, and they're not expected to live that long anyway, they might just say, no thanks, I'm good. I'll be hypertensive, I'll be fine, right? And again, you're going to find that, you know, kind of as things progress along, you're going to go from that treatment to disease for life extension more to just more quality of life. Right? Anyway, looking at the geriatric pharmacology, things we expect to see: cardiac function typically, does it improve or decrease over time? Decrease over time, right? We're going to see LV dysfunction, we're going to see chronic hypertension, we're going to see all those issues. Renal function, decrease, right? Everything is expected to wear out at some point, right? Just like your car, everything's going to wear out at some point or another. And just keep in mind, you need to take this into account, right? I cannot tell you how many patients I've seen come into the ER for drug toxicity for a medication they've been on for the past 15 years, and no one has ever gone back to recheck their renal function. They're on the same dose. Said, well, it keeps working for them, must be fine. Not realizing this insidious creep of drug levels happens over time because no one actually double-checked their renal function. Or they're in the nursing home, they get dehydrated, and all of a sudden the renal function takes a hit, and all of a sudden levels are up, right? Take these things into account. Make sure you're rechecking these patients, the renal function, the hepatic function, because we know it's going to get worse over time, so we need to make sure we're readdressing their drug dosing to make sure it's appropriate still, right? As mentioned, from the GI standpoint, you expect to see things like decreased liver blood flow, especially like in CHF patients. That can lead to decreased metabolism. Things tend to slow down over time. You know, constipation is going to be a big issue for a lot of these patients. It's due to slowed motility, but then you're adding all these medications and supplements on board. You know it's going to happen, right? Now, typically, you're not going to find a lot of differences in absorption just overall from the geriatric GI tract, but you're worried more about drug interactions that occur here, right? So, for instance, if they're taking their Cinemet, when are they ingesting their protein? Because we know those are going to compete for the same binding sites. If you're looking at things like when are they drinking their grapefruit juice, or are they drinking grapefruit juice? Do I need to switch their medication to something that won't interact there? Think about things if they're taking antacids or their calcium supplements. What's that going to bind up? They come in for touch of pneumonia, give them some doxycycline or something, and then they're taking the calcium along with it. Pneumonia's not getting any better. They're taking the medication like they should. What's going on here? They have an interaction there. So all things you want to kind of consider. Okay, what's their diet like? What are they actually ingesting? Because that could be affecting their drugs pretty significantly there. Also think about the changes in distribution for these patients as well. So typically, what happens to, say, body water for these elderly patients? Typically goes down. What happens to muscle mass? Typically goes down. What happens to adipose tissue? Typically goes up, right? So as you can see, you're going to have kind of opposite effects of what you saw in the neonate, right? We're having less body water. We have more adipose tissue, more lipophilic tissue. So what does that do for the volume distribution for a hydrophilic medication? It's going to decrease, right? It's going to be more kind of central versus lipophilic meds. Be more diffuse, right? It's going to have a larger volume of distribution. So we know to expect these changes, and that's why you can see a lot of intervariability in these patients. And again, you may have some very skinny elderly patients, you may have some very overweight elderly patients, and there's a lot of variability there. So that can affect the distribution pretty significantly. Other things like protein binding, right? So as an elderly patient gets older, may see things like albumin levels start to drop. Let's say they're not getting a good diet. They're losing some muscle mass, albumin levels go down. What can that do for my medications? I can see a bigger free fraction of drugs that are highly protein bound. What does that do to maybe the volume distribution for those drugs? Increases it, right? Because they're not stuck in the blood, they can actually partition out into the tissue, right? So those all cause big changes as well. And in fact, a lot of times what we'll do is we can have correction factors. We'll look at the patient's albumin compared to what a normal would be in relation to a drug level and make some assessments about, okay, what's the actual free level like, right? We measure free levels as well, but just keep in mind that it can be a big, you're maybe getting them a standard dose of the drug, but you're seeing toxicity from it. Could be related back to their albumin levels, right? So drug clearance is a really big one I want to harp on because, again, it is something that often goes missed, and it's something that can change pretty rapidly, right? So depending on hydration status of the patient, depending on new medications being added on, renal function can change greatly, and that can greatly affect your patients from the medication standpoint, right? Like I said, I've seen so many patients come to the ER for toxicity based off of changes in renal function that no one caught or no one's been looking at over potentially a very long period of time there. Now, think about it. What we said, creatinine comes from where? Muscle mass, right? So elderly patients, what happens to their muscle mass? It goes down, right? So again, when you find that you have, say, a 90-year-old patient who maybe weighs 90 pounds sopping wet, and you get a creatinine that comes back and it's 0.5, does that seem accurate? Is their renal function really that good? Probably not, right? Because we know they're 90. We know their renal function is not going to, say, preserve that long. So oftentimes you may find they may underestimate what their actual renal, or overestimate, I should say, what their renal function is, and you have to take that into account. A lot of times I have a patient like that, 70, 80, 90 years old, has that low kind of serum creatinine, I'd bump it up to 1, right? Because I'd rather at least be a little bit more conservative with my dosing, and that helps to stay out of trouble in some cases there, right? But keep that in mind. What if they have an amputation? It's going to falsely decrease the creatinine as well, right? So again, a diabetic patient that wasn't taking care of themselves, of blowing the amputation, and all of a sudden the creatinine is lower than what it would be had they had that muscle mass, and I falsely overestimate what their renal function is. And again, what is diabetic? What happens to their renal function over time? It gets worse, right? And diabetic nephropathy is a big thing, right? So again, it may look like they have good function, but really they don't. Based off that creatinine they're able to produce there. So all things you want to consider. And again, hydration status is huge. A lot of times these patients in the nursing homes will go for a while without really being seen by anyone. They get sick. They're not having good oral intake. That can be a really big precipitator of acute kidney injury. Okay. And again, looking at how we do our creatinine clearance, I'm not going to ask you to calculate this on the test by any means, but I want you to at least know the factors that go into it, right? So again, when you have an elderly patient, as they get older, what happens to this value? Because you're subtracting from 140. This gets smaller as you get older, which means the creatinine clearance is going to go down, right? That's factoring in the fact that we know that getting older, we know the creatinine clearance gets worse. Or their weight in kilograms, right? The more they weigh, the higher the creatinine clearance should be, presumably, right? But again, it's all going to be taken into account. You have to take it into perspective. So, for instance, if a patient weighs 500 pounds, is all that actual functional lean body mass? Unlikely, right? So again, based off of that, you may have to do some adjustments there, which I'm not going to talk about, but just know you have to take this into account. And then notice the serum creatinine is in the denominator. So as serum creatinine goes up, what happens to creatinine clearance? It goes down, right? They're inversely related there. So again, you should expect that as a patient's serum creatinine starts to creep up, the renal function is going down. But if I have a falsely low serum creatinine, because they don't have a lot of muscle mass or they have an amputation or something, I'm going to falsely overestimate this, and it may be too aggressive with my drug dosing. Maybe giving drug too frequently, that can lead to problems, okay? Why do we multiply by 0.85 for women? Typically have a little bit higher percentage of body fat than they do muscle mass as compared to men. Is that always going to hold true? Not necessarily. This is just based off the study they did how many ever decades ago, right? If you did this study again today, you may find actual differences, but this is what we work off of for most of our drug dosing. And just know different equations exist out there. This is good for most adult patients. A lot of patients will, especially more geriatric ones, will benefit from this MDRD equation. But one thing I would recommend you asking, especially if you're on your rotations and you see that creatinine clearance that gets printed out at the top of the computer screen, inquire, like, well, how are they actually calculating that? Because if you ask the lab, they may tell you, okay, we use the MDRD equation for patients greater than 65. If everyone wants to use Cockcroft-Gault, that's good information to have, so you know how these things are being calculated. Right? Let's see, other changes, typically drug clearance may go down from the liver standpoint. If you have less blood flow, that's usually more of an issue with patients with ascites and CHF and things like that. For the most part, though, first pass metabolism should be relatively the same unless you have some sort of interaction going on. So for instance, if I have someone who's drinking grapefruit juice, what does that do to first pass metabolism? So what does grapefruit juice do? Inhibits CYP3A4 and that PGP protein. Remember, PGP is an efflux pump that shuttles stuff out into the GI tract. So if you have a CYP3A4 inhibitor like grapefruit juice on board, what does that do to first pass effect? It goes down because the enzymes are not working as well, which means they get more drug into the system. Okay, so if you have a patient taking simvastatin along with the grapefruit juice, what happens to the levels of simvastatin? It goes up, and what can that lead to? Hepatotoxicity and myotoxicity leading to rhabdo, right? Think about these interactions there. So sometimes you may say, well, it's okay for you to drink grapefruit juice. We just need to switch you over to this other medication. And then, oh, insurance doesn't cover that one. Okay, well then maybe cut out the grapefruit juice, right? So again, there's a lot of different ways to skin the cat, but you need to make sure you compromise it is acceptable to you and the patient, right? So again, are patients, or geriatric patients, more sensitive? Not usually. Most of the time it has more to do with the pharmacokinetic changes that happen here. So you may give the same dose as you would to a typical younger adult patient, but again, based on the changes in kinetics, you may find they're just getting much more drug effect than you would see for a younger patient, maybe due to decreased metabolism, etc. But also to think about their homeostatic responses are not as capable, they're not as robust as a young patient would be, right? So for instance, if you go from sitting to standing, you're probably not going to find a whole lot of change in your heart rate and blood pressure because you have a good homeostatic function, right? You're going to find that your sympathetic nervous system can respond very well to that. Elderly patients are going to lose some of that, which means if I give them something like a calcium channel blocker, like an amlodipine or something, that's going to impair their ability to deal with that. So what does that lead to? Orthostatic hypotension, right? So that means less blood flow to the brain. That means they're going to get dizzy. They're going to fall. What if I give them something like a CNS depressant, like a benzo? It won't cause the orthostatic hypotension, but it's certainly going to cloud the mind a little bit, lead to some sedation, dizziness. So again, combining those two together, you can see some synergistic effects there, right? So again, they're losing this homeostatic response, but also the medications are going to be exacerbating these to a pretty big degree there. Okay. So let's look at a few specific drug examples here in the last few minutes that we have. So when you're looking at sedative hypnotic agents, what kind of drugs am I talking about? Benzos are a big one. What else? Benadryls, like first generation antihistamines, fall in this category. Anticonvulsants, yeah, certainly. Barbiturates, right? So it goes in the anticonvulsants sort of category. Anything that's going to cause CNS depression kind of fits in this category. Muscle relaxants, I would also kind of fit in here as well, like your carosoprodols or your baclofens, things like that. Just know that a lot of times you're going to find that the half-lives of these drugs can be extended because they're not metabolizing as well through the liver, or for instance, they may have active metabolites, and they're not able to clear those to the kidneys very well. Good example of that is like diazepam, which is a benzodiazepine. It's a very long half-life in a geriatric patient versus someone who's a little bit younger. If you remember, I talked about 4 benzos that are good for elderly patients. Remember that mnemonic? LOT, right? What does it stand for? Lorazepam, oxazepam. T's are always a problem. Temazepam and triazolam are the 2 ones, right? They either have a short half-life, they are cleared, they're more water-soluble, so they're easier to clear from the kidneys, or they have no active metabolites. Remember when I say active metabolites, it just means you break the drug down and it has an active metabolite there that still does the same thing essentially. So those are the ones we like, right? If you remember, I talked about the beers list before. What is that? Here's a session ale, and here's a saison, and here's a triple, and no, it's a list of medications that we know are going to be problematic in elderly patients, right? Because they cause a lot of orthostatic hypotension, or they cause CNS depression, or they worsen dementia, etc. And so a lot of these drugs are going to be on that list. Doesn't mean you can't use them at all. No, you just need to be very careful using them, right? So if you can try to use a benzo that's going to be more preferable based on their kinetics, that's going to be more beneficial to your patient overall, right? Looking at things like analgesics, right? Looking at opioids. Now, if you remember, what happens with some of like the analgesic effects of opioids over time? You get tolerant to it, right? Remember, you typically see these patients with chronic pain, you're going to have to gently ramp up their dose over time in order to account for that. And again, they can be at very, very high doses. But again, does a thing like constipation ever go away? No. Respiratory effects may still be present, right? So you have to consider these things. And again, obviously, what's the best dose of opioids for a patient? 0 would be great, right? But again, a lot of times you can't get away with that. But imagine mixing a sedative hypnotic plus an opioid. That's where you run into a lot of problems there, right? A lot of elderly patients would show up because they'd be on a muscle relaxant, they'd be on opioid, and they'd be on a benzo, right? Those three together can be quite deadly in some cases, right? To intubate patients because they have so much respiratory depression associated with that, okay? Because again, they all act synergistically to one another. Things like lithium. Remember, what does lithium look like to the body? Looks like sodium, right? So again, it's one of those things where if you're in a salt retentive state, because I give you a diuretic like Lasix, you're going to hold on to that lithium. So this is why we've kind of moved away from lithium in a lot of geriatric patients, because again, they're so prone to changes in renal function that they can see some significant toxicity there, right? Give them an NSAID. What does NSAID do to renal function? Typically decreases it for these elderly patients. And so because of that, they can hold on to more lithium. Right, so you have to be very careful with the renal function and how this can be affected by other medications or just their natural decline over time, right? Antidepressants, these, especially the older ones like your TCAs and your MAOIs, tend to cause a lot of orthostatic hypotension. The antihistamine effects from the TCAs and the antimuscarinic effects tend to cause a lot of changes in mental status, CNS depression, worsened dementia, things like that. Nowadays, we like the SSRIs, so they're generally pretty safe for most of your geriatric patients, and so we like to stick with those as best we can, okay? Cardiovascular agents are always going to be problematic for these patients because, again, you want to get their pressure down, but you're impairing that homeostatic response. So, again, to think about things like the orthostatic hypotension being a big thing here. But also, you think about elderly gentlemen, what's something they run into sometimes that may affect their quality of life? Erectile dysfunction, what a lot of antihypertensives cause. Erectile dysfunction, right? So again, that can be problematic, especially when you're saying, well, I want to prevent you from having a heart attack in a couple of years, but also you're not going to take the medication because you can't have sex with your wife anymore, your partner anymore, right? So these are all things you have to think about with these patients here. Also think about patients with renal disorders. As they get older, are they able to really control their electrolytes as well? No. So think about the effects these drugs are going to have on there. So for instance, if I give someone lisinopril, what's going to happen to their potassium? It's going to go up, right? If I give them Lasix, it's going to go down, right? So know the effects these drugs are going to have, so that way when you use them together, you can expect to see what's going to happen, right? So if I put spironolactone plus an ACE inhibitor, what can I run into? Severe hyperkalemia, right? And you can remember there's a recommendation that actually said don't give spironolactone if their serum creatinine is so high, right? Because you worry about that hyperkalemia there. Same thing with antiarrhythmics. Again, they have that poor reserve, so again, any sort of dysrhythmia may kind of tip them over the edge, and so you have to be aware of that. Be careful with electrolyte disorders because those can aggravate arrhythmias. So again, antiarrhythmics are very, very you have to use them very cautiously, right? And again, you might not be the person prescribing them unless you work for cardiology, but you'll be seeing these patients who are also on these meds who are seeing their cardiologist. So you have to be careful because if you were to say give them some Lasix, put them on lisinopril, and they're on quinidine from the cardiologist, you start to see where you can run into some issues with those electrolyte shifts, right? Anyway, so again, we know the more drugs you're on, the more likely you are to have an adverse drug reaction. But also keep in mind the OTC and the herbal meds, right? Now again, how do you ask about herbal meds? How do you ask about OTCs is really important. Again, make sure you're using a curious and not judgmental sort of standpoint when you ask these questions. Make sure to ask open-ended questions. Otherwise, you're not going to get the full picture, right? So again, like, hey, do you ever use anything you get from the GNC, right? Do you ever use anything that maybe you get without a prescription, right? It'll be like, you don't use the herbals, do you? You're using that hocus pocus stuff, right? Like, they're not going to tell you. They're not going to be forthright with you. So again, you need to be cautious or be curious, not judgmental, and that can really help you to get the full picture there. Because again, these medications, whether you think they work for their intended disease states or not, guess what? They still have significant physiologic effects, I've had patients who were taking ginkgo. Ginkgo's good for memory. But also taking warfarin, had a massive head bleed, died, right? So again, these can still be very potent agents. You have to be very careful with them, though. Okay. Again, think about things like prescriber errors, like not taking into account organ function changes over time. Very important to consider there. And also compliance errors, right? So again, whether the patient is taking it as they are intended to, maybe they misunderstood you, maybe they don't have a good caregiver that is there to help them take the medications correctly. That can lead to errors. And then just seeing the multiple providers is a huge one. There's so many different providers all making recommendations. Oftentimes they're counterintuitive, counterproductive. Sometimes they're synergistic. You can find all kinds of problems. So you as a central person, if you are that person, needs to really be an advocate for the patient. Be like, well, if you see something weird or that doesn't really make sense to you, you got to ask the questions, right? Not only that, but a lot of patients may not even see medications as medications. I mentioned BC powders, the Goodies powders. Tends to be kind of a southern thing where there's aspirin in there, right? And you got to be careful with the aspirin because they might be taking it for heart attack prevention. They might be taking it for their headaches now and these BC powders, and so they can get very high levels very quickly if they're not careful. So anyway, so again, this last little bit here is just about asking good questions, right? Make sure you're asking good open-ended questions. Do you take over-the-counter medications? Well, that's a yes or no question, right? You may not get as full information. You say, well, what do you take that you can get without a prescription? Trying to get a little bit more information out of them is always going to be useful there, right? Do you have pain? Yes, no, right? But you can say, what kind of pain are you having? Describe it to me, right? When you ask about how they're taking their medication, don't just say, are you taking the medication like I told you to? Because what are they going to say? Yeah, of course I am. They don't want to disappoint you. They don't want the look of shame from their provider. However, if you say, tell me how you take your medications, that way they actually have to walk through it and they can tell you specifically how they're doing it. You can catch them if they're making an error somewhere, right? If you talk about they're using inhalers for their asthma or COPD, show me how you use your inhaler, right? Because technique is super, super important for those. If they're injecting insulin or Humira or something like that, have them demonstrate to you, right? Because a lot of times if they have rheumatoid arthritis, if they have osteoarthritis, they may not be able to do that. They may not have the dexterity to do so, right? Also ask about things they're getting from other people, right? Especially if they're on a fixed income. They may not want to, may want to use their sister's Zithromax, extra Z-Pack that she had lying around, right? Or they might be trying to get stuff from Canada, right? They might try to be getting stuff from other places. So always ask these questions to see where they're getting stuff from. And then check expiration dates. I will tell you, I went to a brown bag event one time when I was a student and basically went to a nursing home. And we had these patients bring out their brown bags full of all their medications. Saw stuff that expired in the 80s. Saw stuff that they had been taking, they'd been discontinued a year ago. So again, these are really good opportunities to go through and be like, okay, well, let's throw this stuff out. This is no good anymore. You're not even taking this anymore. Because again, elderly people, especially when they're on a fixed income, what do? They like to hoard stuff, right? You got to Marie Kondo their med list, so to speak, right? So thank you for your service and get out of here. We're not taking this anymore. Anyway, and again, ask about how are they remembering to take their medications. Are they using an app? Are they using clocks, an alarm, anything like that, to make sure they are remembering to take their stuff like they're supposed to, right? And if they miss a dose, what do they do to catch up, right? Because again, it could be inappropriate the way they're doing it. They say, oh, I missed 2 days. I took 3 times the dose on the 3rd day. That's not appropriate, right? Little things to think about. It was just some ideas, ways that can help to remind themselves on how to take these medications here. Again, they have a nice braille on here, so if you have visual impairment, different ways to skin the same cat, just help them, educate them on how they can try to remind themselves to take their meds like they're supposed to. Anyway, so there's a lot of issues with compliance. Try to use cheap stuff if you can. Try to use combo stuff if you can, because again, that helps with decreasing the pill burden. And think about things like intelligent non-compliance. What is intelligent non-compliance? They're doing stuff on purpose, but they may not want to tell you about it, right? So they're like, man, I can't really afford all my medications here, so I'm going to go ahead and take a half pill once a day instead of a whole pill twice a day, right? And again, when you ask them about it, what are they going to say? Oh, yeah, I'm taking it just like you told me. So again, ask about that sort of thing. And again, by being curious, just say, hey, I don't care if you're taking it wrong. Just tell me how you're taking it, so that way we can try to get you to the right thing. Because you may be able to find, if you identify obstacles, you can try to find ways to get around them, right? Anyway, so that is the end of the material. If you have any questions, I can answer for you at this moment. Okay. So again, this is my last class with you guys. You've been a wonderful class. Thank you so much for the great year. I think you're all going to be excellent PAs, excellent colleagues one day. Oh, seriously, my videos. That's so sweet of you guys. You guys are so nice. My videos will be up in perpetuity until YouTube shuts me down, maybe. So go back and review stuff. You have my email address. You can always reach out and contact me. If you ever see something weird or interesting, like just reach out. Like, you know, just because you're not my student anymore doesn't mean we're not colleagues, right? We may be working in the same hospital one day. You never know. I work with a lot of people I've graduated over at Nemours, so you may be one of those people. Who knows? But anyway, just always look stuff up, please do that, and get to know your local pharmacist. You don't have to give them as nice a gifts as these, but oftentimes they like chocolate and things like that. Just so they can save your butt sometimes. So if nothing else, yes, ma'am.
So if we have a question during clinicals, I mean, we can always ask.
Why not? Yeah, just email me. You know, have a conversation about it. Just see if you see something weird or interesting. Yeah, reach out. It's not a problem. You know, like I said, just because you're not my student actively anymore doesn't mean that we're not colleagues, right? So again, just like I'd ask any other provider, hey, this is weird. What do you think about that, right? Same thing applies. Let me check the board real quick to see if there's anything on there. Thanks for sticking with me a little late. No questions whatsoever, so that's fantastic. I answered them all already. All right, well, thank you so much, and